All right, folks. Well, welcome to our last Department of Medicine Grand Rounds of the 2020 year. With us closing out this calendar year, I am happy to introduce Dr. Yilin Zhang, who initially got her PhD, or excuse me, her MD at the University of Pittsburgh, and then came here to the University of Washington to complete her internal medicine residency, and stayed with us at the University of Washington as a hospitalist through July 2020, but recently took the position of Assistant Program Director for Inpatient Clinical Teaching at Valley Medical Center for the Valley Family Medicine residents. And so happily, I'm here to introduce her to give us an update in hospital medicine, which is pertinent to all of us. So I will hand over the digital podium and let you take it away.
Awesome. Thank you so much for the gracious introduction, Alana. For those who don't know me, my name is Yilin, and today I'll be giving an updates in hospital medicine talk. So a few disclosures. First, I'm not a subspecialist. I'll be looking at the various papers that I'll be presenting today through the lens of an internist, but I did try to compile as many subspecialty opinions as possible for you guys, and I have no other disclosures. Just an outline of my process. I looked at the primary literature in major medical journals over the past year and identified those that impacted patient care on the inpatient side, and excluded any COVID literature, just because that would be a talk in and of itself. We'll talk about updates in 5 major subspecialties: infectious disease, nephrology, cardiology, gastroenterology, and endocrinology today. So it's a lot to get through. By the end of this talk, I hope that you guys will be able to identify when beta-lactams can be used as oral step-down therapy, assess the risk of aortic aneurysm and dissection with fluoroquinolones, distinguish between contrast-associated and contrast-induced AKI, manage patients with AFib, in particular those with new onset AFib and those with concurrent end-stage renal disease, determine the importance of early endoscopy in upper and lower GI bleeds, and lastly, recognize the prevalence of DKA as a side effect of SGLT2 inhibitors. This is an interactive talk, so please participate. I'll be using Poll Everywhere, and so you guys can join either through your computer at pollev.com/yilinzhang921, or you can text yilinzhang921 to the number 22333 in order to join. No worries if you don't get all of this information down. It'll be presented on every slide where it's relevant. All right, so let's go ahead and get started. So first we'll be starting with an updates in infectious disease. And the 2 major themes that I identified in the literature this year were the use of beta-lactams as oral step-down therapy for strep and GNR bacteremia, and also the risk of aortic aneurysms and dissections with fluoroquinolones. Let me introduce Mr. A. He's a 76-year-old man with a history of hypertension and hyperlipidemia, and he's coming in with sepsis from pyelonephritis. His blood and urine cultures grow E. coli that's resistant to fluoroquinolones and Bactrim, but sensitive to ceftriaxone. He clinically improves in the hospital with IV ceftriaxone, and on hospital day 3, he'd like to discharge home. My question to you is, can he be transitioned to oral beta-lactam therapy? So I'll turn it over to you guys. What do you think? Can patients with GNR bacteremia be transitioned to oral beta-lactam therapy? No, he should continue IV antibiotics. Or yes, you can switch to an oral cephalosporin. I'll give you guys a few moments to answer. All right, let's see what you guys said. And if you didn't get a chance to answer this one, no worries. And so it looks like we're pretty split between continuing IV antibiotics and oral cephalosporins. here I want to convince you guys that it would be reasonable to switch to an oral beta-lactam. So over the past few years, there's been a trend towards using oral step-down therapy. In 2018, the POET trial came out looking at oral step-down therapy in endocarditis. The OVIVA trial came out at the same time, looking at bone and joint infections. And then in 2019, another trial by Tama et al. Looked at GNR bacteremia. However, all of these studies relied heavily on highly bioavailable oral antibiotics such as fluoroquinolones and Bactrim. And in GNR bacteremia in particular, there's been increasing resistance to these antibiotics. And with fluoroquinolones specifically, there's been increasing concern about adverse events, specifically an increased risk of aortic aneurysm and dissections. Beta-lactams traditionally have much lower bioavailability. There's no guideline recommendations on oral antibiotics for GNR bacteremia. So this paper came out in JAMA just a few months ago, looking at oral beta-lactams for Enterobacterales bacteremia. It was a retrospective cohort study, and it sought to compare the effectiveness of beta-lactam antibiotics versus fluoroquinolones or Bactrim for GNR bacteremia from a urinary source. They looked at 4,000 adults hospitalized with a positive urine and blood culture for E. coli, Klebsiella, or Proteus who had received a few days of IV antibiotics. They intentionally excluded anybody with a polymicrobial bloodstream infection or those with inadequate source control or a reason for prolonged antibiotic therapy. This was split into two cohorts, one who had received fluoroquinolones and Bactrim, and another who had received beta-lactams. And outcomes were looked at through 30 days. The primary outcome was a composite of all-cause mortality and recurrent bacteremia. On average, the patients were older, mean age of 71, and this was a VA study, so 91% of the patients were male. The beta-lactam group had more pre-existing urologic conditions, but otherwise the groups were pretty well balanced. About 25% of patients each received Augmentin, cephalexin, or ceftriaxone as their oral step-down therapy. And in the fluoroquinolone and Bactrim group, ciprofloxacin was overwhelmingly the most common antibiotic used. When we look at the antibiotic duration, patients received on average either 4 or 5 days of IV antibiotic therapy and a total of 14 days of antibiotic therapy. In terms of the primary outcomes, there were no significant differences between the two groups, and also no differences when we looked at the individual components of mortality or recurrent bacteremia. They had similar results when they looked out to 90 days. So in conclusion, in uncomplicated Enterobacterales bacteremia from a urinary source, oral step-down therapy with beta-lactams was not associated with higher mortality or recurrent bacteremia. Some of the strengths of this paper was that this was the largest cohort to date that I could find on this topic. However, it's still a retrospective and observational study, and so we have to take its conclusions with a grain of salt. It has limited generalizability because it included older men and may not be applicable to patients who are initially admitted to the ICU. And more evidence is coming out that a shorter duration of therapy, as short as 7 days, may be adequate for GNR bacteremia. And because these patients received on average 4 to 5 days of IV antibiotics, they might have received actually most of their treatment with IV therapy. And so coming back to Mr. A, can he be transitioned to oral antibiotics? And I would advocate for yes in this case. Oral beta-lactam therapy may be a reasonable step down for select patients with uncomplicated GNR bacteremia from a urinary source. And despite the fact that the patients in this study were transitioned relatively late into their antibiotic course, the majority of ID specialists feel that you can do oral step-down therapy as soon as the patient is afebrile and hemodynamically stable. But a word of caution is that this does not apply to MDR and ESBL organisms, and so we should involve our ID colleagues for those. All right. Now let's talk about a hypothetical situation. What if Mr. A, instead of coming in with E. coli bacteremia, came in with strep pneumobacteremia from a right lower lobe pneumonia? He's empirically treated with IV ceftriaxone and azithro and clinically improved. On hospital day 4, he's ready for discharge, but you're concerned about the side effects of fluoroquinolone therapy. Can he be transitioned to oral antibiotics, specifically oral beta-lactams? I'll turn it over to you guys. What do you think? Can a strep bacteremia be treated with oral beta-lactams? All right, let's see what you guys said. And so the majority of you guys said yes. And I would agree. And hopefully this next paper convinces you guys as well. And so this was a multi-center retrospective cohort study comparing fluoroquinolones versus beta-lactam oral step-down therapy for strep bacteremia. They included 220 patients who were hospitalized with strep bacteremia and separated them into a fluoroquinolone and beta-lactam cohort. Patients were followed through 90 days, and the primary outcome was clinical success, which was a composite of lack of all-cause mortality, recurrent bloodstream infections, and lack of infection-related readmissions. Patients on average were 64 years old, well balanced between men and women. The median time to oral antibiotics was between 5 to 6 days, and the total treatment duration was again 14 days. Strep pneumo was the most common organism, followed by group A strep. In terms of the outcome, for the primary composite outcome of clinical success, they found that beta-lactam therapy was non-inferior to fluoroquinolones, and there was also no significant differences between any of the composites of clinical success. The one predictor of clinical failure, however, was if patients were transitioned to oral antibiotics within 3 days. And so coming back to Mr. A, can he be transitioned for oral beta-lactams? And I would say yes, oral beta-lactams may be a reasonable step-down therapy in select patients with strep bacteremia after the 3rd day of treatment. Few words of caution. This may not apply to all streptococcal species, in particular strep viridans, and some of our ID colleagues have also expressed some reservations about group A strep bacteremia. And so we can feel pretty good as internists to treat strep pneumobacteremia from a pneumonia on our own, but otherwise touch base with our ID colleagues prior to transitioning to oral beta-lactam therapy. All right, now another hypothetical situation. Mr. A is back with E. coli pyelonephritis, but this time his sensitivities show resistance to all oral antibiotics except fluoroquinolones. In the hospital, he's treated with Zosyn, and on hospital day 3, he's stable and requesting to go home. How would you manage this patient? Would you place a PIC to complete IV therapy as an outpatient, discharge on oral antibiotics, oral fluoroquinolones specifically, or do you have some other thoughts? Feel free to type in the chat group. So actually, I might not be able to see the chat. Sorry about that. All right, let's see what people have said so far. Looks like most of you guys feel comfortable discharging on oral fluoroquinolones. I didn't put a right answer here, but I would be inclined to agree in this situation. So let's talk a little bit about the risk of fluoroquinolones with aortic aneurysm and dissections. At the end of 2018, the FDA put out a warning label that fluoroquinolones increase the risk of dissection in certain patients. This was largely based on prior observational studies that showed a twofold increase in the risk of aortic aneurysm or dissection. However, there were some notable limitations in these studies. First, there was a risk of residual confounding. These observational studies compared fluoroquinolone therapy to amoxicillin, a significantly narrower antibiotic, or no antibiotics at all. And so the comparator groups might have been healthier. There's also a risk for surveillance bias. The infections for which fluoroquinolones are used might have led to more imaging, which would have caught more aortic dissections or aneurysms. So there were two major papers that came out in JAMA Internal Medicine this year, seeking to clarify the association of fluoroquinolones with aortic aneurysm and dissection. The first of these was an observational cohort study, which sought to assess the association of fluoroquinolones with aneurysm and dissection while accounting for all these confounders that had plagued prior observational studies. They looked at a large commercial U.S. health insurance claims database, excluded patients who were younger than 50 years old, had a history of aortic aneurysm or dissection, or had a recent hospitalization, and split them into a pneumonia and a UTI cohort. They did this to account for residual confounding secondary to antibiotic indication. The pneumonia group was then split up into those who received fluoroquinolones and those who received azithromycin, and the UTI cohort into those that received fluoroquinolones and Bactrim. They then underwent one-to-one matching based on comorbidities, demographics, and medications, and they were followed through 60 days. The primary outcome here was hospitalization for aortic aneurysm or dissection. Looking at the pneumonia cohort, the average age was 63, about 54% female. And for the primary outcome, fluoroquinolones were associated with a significant increase in aneurysms or dissection. But notably, they were unable to control for baseline imaging here, so they could not account for surveillance bias because the patient population was not large enough. In the UTI cohort, the mean age was 62, and it was overwhelmingly female. And here, there was no significant difference between fluoroquinolones and Bactrim, and they were able to control for baseline imaging in this setting. So the authors concluded that fluoroquinolone use may be associated with an increased risk of aneurysm and dissection with pneumonia, but not with UTIs. Then they did a subgroup analysis, essentially attempting to replicate one of the older observational studies. They went back to that U.S. claims database, excluded the same patients, and then split patients up into those who had received fluoroquinolones and those who had received amoxicillin, regardless of the indication for the antibiotic. They also underwent one-to-one matching, and even after matching, they found that the fluoroquinolone group had a higher rate of baseline imaging. When they didn't control for this baseline imaging, they found that the fluoroquinolone group did have a higher risk of aortic aneurysm and dissection. But once they controlled for baseline imaging, therefore accounting for the surveillance bias, they found that this increased risk was no longer significant. And so they concluded that fluoroquinolones compared to amoxicillin did not increase the risk of aortic aneurysm or dissection when controlled for baseline imaging. Now let's talk about that second paper in JAMA. This was a nested case control study they used a Taiwanese health insurance database and split patients up into those who had a new diagnosis of aortic aneurysm or dissection and those who did not. They looked back 60 days from the new diagnosis and identified a subset who had had infections within that time and matched them against controls based on demographics, infection, follow-up duration, and notably aortic aneurysm and dissection risk factors. The first objective and outcome that they wanted to look at was to estimate the risk of aortic aneurysm and dissection associated with infections. What they found is that patients with an infection had a 2 to 4-fold increased odds of aneurysm or dissection, irrespective of antibiotic use. And this risk was highest among those who had intra-abdominal infections and those who had sepsis. The second objective and outcome was to assess the risk of aortic aneurysm and dissection with fluoroquinolones compared to other antibiotics. And so with their matched cohort, they excluded anybody who was on more than one antibiotic and split patients up based on antibiotic therapy. Those who were on fluoroquinolones only, those who received Augmentin or Unison, and those who had received a cephalosporin. And what they found was that compared with patients on amoxicillin, on Augmentin or Unison, and cephalosporins, patients on fluoroquinolones were not at increased risk of aneurysm or dissection. And so, what can we conclude from these two studies? Fluoroquinolone use may be associated with a small increased risk of aneurysm or dissection, but the overall absolute risk was still low, less than 0.1%. Infections alone are associated with an increased risk. And compared to other antibiotics, fluoroquinolone use did not increase the risk of aneurysm or dissection. There's some notable limitations. And so in that first study we talked about, patients were relatively young, and they did not specifically control for risk factors for aneurysm or dissection. So it's possible that they were a healthier group. In that second paper we talked about, there's limited generalizability because it was carried out in Taiwan. And there was a pretty limited sample size when comparing different antibiotics. And so this third conclusion we'll have to take with a grain of salt. And so overall, in this patient with E. coli pyelonephritis that's only sensitive to fluoroquinolones, can he safely be transitioned to oral fluoroquinolones? And I would advocate for yes in this situation. From these two papers, it's unclear whether fluoroquinolones truly confer an increased risk of aneurysm and dissection. And when appropriate, the benefit of fluoroquinolone therapy may outweigh a small potential increase in the risk. A few words of caution: the fluoroquinolones still have many, many other side effects that you should consider. And overall, our ID colleagues still think that there is an increased risk, even if it is small. And so in patients with aneurysm and dissection risk factors, such as Mr. A, who has hypertension, hyperlipidemia, you should still engage in a risk-benefit discussion with the patient before initiating fluoroquinolone therapy. All right, so let's conclude the infectious disease section and talk about the take-home points. Oral beta-lactam therapy can be considered for step-down in therapy in select patients with uncomplicated Enterobacterales and Strep bacteremia. But consult with ID if it's ESBL organisms, Group A strep or Strep viridans. When indicated, the benefit of fluoroquinolone therapy may outweigh a small potential risk in aortic aneurysm and dissections. Okay, now let's move on to updates in nephrology. The two major themes here for this year were contrast-associated AKI and anticoagulation in AFib and end-stage renal disease. So I'm going to introduce Mr. B. He's an 83-year-old man with a history of hypertension, CAD, CKD3, who presents with subjective fevers, abdominal pain, and nausea and vomiting. His initial labs are notable for an elevated white blood cell count of 13, a creatinine of 2.1 from a baseline of 1.7, so GFR of 37, and you'd like to obtain a CT scan to rule out an intra-abdominal infection. What is the risk of AKI with IV contrast? What do you guys think? Is there no risk? Go ahead and pursue a CT scan with contrast. A potential but minimal risk, so prehydrate with IV fluids, then pursue a CT scan with contrast. Or he's at risk and you should try to pursue a non-contrast study. I'll give you guys a few more moments. All right, let's see what you guys said. The majority of you guys chose minimal risk, prehydrate, and proceed with a CT scan. And that's what I would agree with. And let's talk about what the evidence shows. So how does contrast cause AKI? Well, historically, contrast was hyperosmolar, which led to renal tubular necrosis, fluid shifts, which led to renal vasoconstriction via a few different mechanisms. And all of these things would decrease GFR. However, now our contrast is isoosmolar, and the risk of renal injury is felt to be significantly lower. This year, the American College of Radiologists and the National Kidney Foundation put together a consensus statement on the use of IV contrast in patients with CKD. They differentiate between contrast-associated AKI with contrast-induced AKI. Contrast-associated AKI is coincident AKI that occurs within 48 hours of receiving contrast. This acknowledges that patients who need IV contrast have other risk factors for AKI, and it may not be the contrast that actually caused the renal injury. Contrast-induced AKI, which is a subset, implies causality between the contrast and the AKI, and also usually occurs within 48 hours. They looked at a number of papers across the literature and found that the incidence of contrast-associated AKI does increase as your GFR decreases, up to 30% in patients with a GFR less than 30. But when we look at the subset of contrast-induced AKI, so AKI as a result of the contrast, you'll find that for patients with a GFR above 30, there is negligible risk. And even with patients with a GFR less than 30, there's a wide range that was reported, 0 to 17%, and this is largely based on observational studies. And so what they recommended was that for patients with a GFR of 30 to 44, you should prehydrate with normal saline if patients are at high risk. And for patients with a GFR less than 30, you should prehydrate with normal saline, but also discuss the risks and benefits of receiving IV contrast. So Mr. B, what is his risk of AKI with receiving IV contrast? Well, he has a GFR of 37, and for patients with a GFR greater than 30, IV contrast is unlikely to be associated with any significant renal injury. And even for patients with a GFR less than 30, if a contrasted study will confer critical information, that study should likely be performed. All right. Moving back to Mr. B, he was diagnosed with sepsis secondary to diverticulitis after he got a CT scan. His hospital course then has been complicated by progressive AKI and was started on hemodialysis. On hospital day 4, he develops new onset AFib. The TTE shows no significant valvular dysfunction, and his CHADS VAS score is 4. He has no major history of bleeding events, How would you manage his AFib? And so my question to you guys is, in a patient with AFib on dialysis, what would you use to decrease his stroke risk? Would you guys choose Warfarin, Apixaban, Rivaroxaban, Dabigatran, or no anticoagulation at all? I know we're about halfway through, but for anybody who hasn't used Pull Everywhere yet, you can text Yilin Zhang 921 to the number 22333 and text in your answers, or go online to pullev.com. Let's see what you guys said. And so we're pretty split. It sounds like most people think Warfarin or Apixaban. Ooh, the majority of people think Warfarin over Apixaban. So here, what I would advocate is the 3 acceptable answers: Warfarin, Apixaban, or no anticoagulation at all. Let's review the literature on this. So AFib management is all about balancing your thromboembolic risk with your bleeding risk. Unfortunately, with patients on dialysis, they are at increased risk of both. However, providers tend to overestimate the thromboembolic risk and underestimate their bleeding risk. There have been several studies over the past few years looking at whether there is a benefit to anticoagulation in this specific patient population. This meta-analysis in 2017 of over 20,000 patients found that there was no difference in ischemic stroke, all-cause mortality, or bleeding between patients who received warfarin and those who received no anticoagulation. Another study out in 2018 that looked at Apixaban versus warfarin found that Apixaban was not associated with any difference in stroke and systemic embolism compared to warfarin, but did have a lower associated bleeding risk. The 2019 ACC-AHA atrial fibrillation guidelines recommend that it may be reasonable to consider Apixaban or warfarin in patients with end-stage renal disease. Interestingly, from the nephrology perspective, the KDIGO in 2011 has actually recommended that routine anticoagulation not be considered for patients with AFib on dialysis. This recent paper out in JACC was a networked meta-analysis of 16 observational studies that sought to assess the safety and efficacy of DOACs and warfarin compared to no anticoagulation for patients with AFib on long-term dialysis. So a network meta-analysis allowed them to compare several studies that may not have had the same comparison groups. So for the primary outcome of stroke or systemic embolism, they looked at 14 papers that compared no anticoagulation with warfarin, one paper that compared Apixaban 5 milligrams with warfarin, one paper that compared Apixaban 2 milligrams with warfarin. For the outcome of all-cause mortality, a similar number of papers comparing Apixaban to warfarin or warfarin to no anticoagulation. And then for the outcome of major bleeding, they looked at several other papers that compared DOACs with warfarin. And what they found was this: Apixaban and warfarin did not reduce stroke or systemic embolism compared to no anticoagulation. So there was significant heterogeneity in these results. For all-cause mortality, interestingly, the higher dose Apixaban, 5 milligrams twice daily, was associated with the lower all-cause mortality, but compared to no anticoagulation, the lower dose Apixaban or warfarin. but again, there was significant heterogeneity in this study as well. And for the safety outcome of major bleeding, Apixaban was equivalent to no anticoagulation. Apixaban and no anticoagulation were associated with lower bleeding risk than Warfarin, dabigatran, or rivaroxaban. And Warfarin was associated with lower bleeding risk than dabigatran. There was no significant heterogeneity with the major bleeding outcome. So based on this study, oral anticoagulants were not associated with a decreased risk of thromboembolism in patients with AFib on long-term dialysis. And Warfarin was actually associated with a higher risk of bleeding than no anticoagulation or Apixaban. The strengths is a large meta-analysis, but there was high heterogeneity in all of the findings. And there was limited data on DOACs. If you guys noticed, for the primary outcome of thromboembolism or stroke, all but two papers were looking at Warfarin versus no anticoagulation. And because these were retrospective observational studies, there may be unaccounted for differences in patients who were prescribed DOACs versus Warfarin that we're not able to control for. Now let's take a look specifically at Apixaban versus Warfarin in patients with end-stage renal disease. This was a retrospective cohort study in Blood Advances out earlier this year that looked at 861 patients with end-stage renal disease. They separated these patients into a Warfarin and Apixaban cohort and followed these patients out 60 days. And the primary outcomes were time to first bleed or thrombosis, and secondary outcomes were thrombosis and bleeding rate. And what they found were that people in the Apixaban group were significantly older and had more comorbidities than the Warfarin group. And the Warfarin group had significantly more women and had a higher percentage of patients who were being treated for a venous thromboembolism. For the secondary outcomes of thrombosis and bleeding, there was a non-significant difference between Warfarin and Apixaban, though the absolute numbers in the Warfarin group were higher. For the primary outcome, the risk of thrombosis or bleeding was lower in the Apixaban group, especially when adjusted for other confounders, such as AFib or cabbage. And interestingly, again, the higher dose Apixaban, the 5 milligrams BID, was actually better than the lower dose Apixaban or Warfarin. And this was largely due to a significant decrease in the number of bleeding risks. So coming back to Mr. B, he has new onset AFib and is now on hemodialysis. How can you decrease his stroke risk? And so anticoagulation may not decrease the risk of thromboembolism in patients with AFib on dialysis, but more studies are needed on this. If you talk to cardiologists, the majority of them favor anticoagulation, but if you talk to nephrologists, a lot of them favor not anticoagulating. If you do choose to anticoagulate, Apixaban 5 milligrams BID may be a safe and effective alternative to Warfarin. Okay, now let's move on to updates in cardiology. And here the theme of the year is rate versus rhythm control. So let's go back to Mr. B. He's coming in with sepsis secondary to diverticulitis. His hospital course was complicated by AKI, a new onset non-valvular AFib. His heart rates are in the 120s, but he's largely asymptomatic. How would you manage his new onset AFib? Would you pursue a rate control strategy or consult cardiology for rhythm control? Let's see what you guys have said so far. Looks like we're pretty evenly split between rate and rhythm control. So let's look at the new literature that has come out regarding this. Current guidelines recommend a rate control strategy for AFib, except in the setting of AFib-related symptoms. And this was largely based on the AFFIRM trial from 2002, where they found no difference in mortality or ischemic stroke at 5 years between rate and rhythm control. However, that study also showed that more patients in the rhythm control group maintained sinus rhythm at 5 years. And a post hoc analysis of that, apologize for that. But a post hoc analysis of FIRM showed that there was no improved mortality with sinus rhythm. Sorry, there was improved mortality with maintenance of sinus rhythm. Most of the rhythm control group received sotalol or amiodarone in the AFFIRM trial, but since then, newer antiarrhythmics such as flecainide or dronedarone have come out, which are better tolerated. And we're getting better at catheter ablation. In fact, the Cabana trial came out last year, which compared antiarrhythmics to ablation and found that ablation decreased recurrent AFib and cardiovascular mortality and hospitalizations. And so the EAST-AFNET trial just recently came out in the New England Journal of Medicine. This is a parallel group, open, blinded, randomized control trial, which sought to evaluate the effectiveness of rate versus rhythm control in patients with early AFib in cardiovascular conditions. They looked at 2,800 adults with AFib that had been diagnosed within the prior year, who were either older than 65 with a prior TIA or CVA, or had multiple other risk factors or cardiovascular conditions. So they needed at least 2 of the following. These patients were randomized to either usual care or rate control, or rhythm control, in which they were given either antiarrhythmics or ablation. On average, patients were randomized 36 days after their AFib diagnosis. They were followed through a median of 5 years. The primary outcome was a composite of cardiovascular death, stroke, or hospitalization, and the secondary outcome was the number of nights spent in the hospital. The mean age was 70, pretty balanced between men and women, and the average CHADS-VAS score was 3. The usual care group had more patients on beta blockers and digoxin, but this may be expected since they were in the rate control group. 53% of patients were in sinus rhythm at the time of enrollment, and 30% were asymptomatic. And they were pretty evenly distributed between those who had had their first episode of AFib, paroxysmal AFib, or persistent AFib. Looking at who received rhythm control in the first year, 96% of the usual care group did not receive any rhythm control within the first year. In the rhythm control group, about 8% of patients received ablation. The most common antiarrhythmic was flecainide, followed by amiodarone and dronedarone. For the primary outcome, the composite of death, stroke, and cardiovascular hospitalizations, that was significantly lower in the early rhythm control group. In fact, this was so significant that they actually terminated the study early. Looking at other efficacy and safety outcomes, there was no difference in the number of nights spent in the hospital. More patients in the rhythm control group maintained sinus rhythm at 2 years, and this was significant. And there was no significant difference in overall safety outcomes, which was a composite of stroke, death, and adverse events. If you separated out these adverse events, however, the rhythm control group was associated with a significantly lower risk of stroke and a significantly higher risk of adverse events. So in conclusion, early initiation of rhythm control can reduce cardiovascular events compared to rate control without affecting nights in the hospital. This is a large, multi-center randomized control trial, but they did have some limitations. Overall, there were relatively low event rates, lower than what they had expected. It would not be generalizable to chronic AFib. Interestingly, they included several patients who were asymptomatic or minimally symptomatic. So you can make the argument that this is the patient population that we're most likely right now to treat with rate control. So it's helpful to understand that rhythm control may actually improve their outcomes. And a non-significant percentage of patients were lost to follow-up. So how would you manage Mr. V's new onset non-valvular AFib? I would say that we should consider early rhythm control strategy in patients with early AFib with other cardiovascular risk factors, because this may reduce death, stroke, and other hospitalizations. And so considering consulting our cardiology colleagues or referring our patients to them early. All right, now let's move on to updates in gastroenterology. We have about 12 minutes. I think we can get through all of it, but if at any point you guys would rather spend that time asking questions, just let me know. So the themes here are to talk about the timing of upper and lower endoscopy and GI bleeding. Mrs. C is a 49-year-old with a history of type 2 diabetes, HFrEF, who presents with syncope and melena. She's been taking ibuprofen following a recent injury. In the ED, she's tachycardic, mildly hypotensive, and she had a 2-point drop in her hemoglobin. Her Glasgow-Blatchford score indicates she's at high risk of death or further bleeding. You notice that the time is just before midnight. In addition to standard management of upper GI bleed, how urgently would you consult GI? Would you consult them now? She needs an EGD within 6 hours. Would you consult them first thing in the morning? She needs an EGD within 24 hours. Or consult them non-urgently. We should focus on medical stabilization. A few of you guys have answered, but just to move things along, let's see. Most of you guys would say that the GI can be consulted in the morning, and she needs early EGD within 24 hours. And I would agree with that. And so let's talk about the timing of endoscopy and upper GI bleeds. Overall, upper GI bleeds are associated with pretty high mortality of about 10%. And current international consensus group recommends that you'd perform endoscopy within 24 hours of presentation. However, for patients who are at high risk of bleeding or death, the role of more urgent endoscopy within 2 to 12 hours is unclear. This randomized control trial in the New England Journal of Medicine sought to evaluate if urgent endoscopy improves outcomes in upper GI bleed. They enrolled 600 adults who were admitted with upper GI bleed who were at high risk of further bleeding or death. They excluded anybody who was in shock. They randomized them to urgent EGD within 6 hours or early EGD within 24 hours and followed these patients through 30 days. The primary endpoints were death from any cause, further bleeding, or hospital length of stay. These patients were on average 70 years old, predominantly male, and very few patients had cirrhosis. PUD was overwhelmingly the majority cause of GI bleeds in this study. And when they actually looked at the timing of endoscopy from presentation, the urgent EGD group actually received endoscopy on average about 10 hours from presentation, and in the early group, about 25 hours from presentation. Looking at outcomes, urgent endoscopy led to more identification of bleeding ulcers and more endoscopic treatment, significantly more here. But when you look at outcomes, there was no difference in mortality, further bleeding, or hospital length of stay. And I'd just like to point out that there were pretty high rates of mortality and further bleeding, just had previously been shown in the literature. So from this paper, we can conclude that in high-risk upper GI bleed, urgent endoscopy within the first 6 hours versus 24 hours increases endoscopic treatment, but does not necessarily improve outcomes. This is a randomized controlled trial which enrolled high-risk GI bleeds, but there was limited generalizability because this was conducted in Hong Kong and the patients were generally pretty healthy. There are very few variceal bleeds, and they excluded patients with shock. And also, what they truly evaluated was endoscopy within 10 hours versus 25 hours. And so the true benefit of urgent endoscopy within the first 6 hours is still unknown. And so for Ms. C, I would agree with you here. In patients with non-variceal, hemodynamically stable high-risk GI bleeds, urgent endoscopy within the first 6 hours may not actually improve outcomes. But this likely can only apply to patients with ulcerative bleeds, and we should not, this is not generalizable to patients with cirrhosis. Now, what if Mrs. C came in with hematochezia? She came in with the same vitals, same 2-point drop in her hemoglobin. She gets an EDD, which ruled out upper GI bleed. How urgently does she need a colonoscopy? What do you guys think? ASAP, within 24 hours, or within the next few days? Oops, sorry about that. And just for time, let's see. It actually looks like we're pretty well spread out. So let's take a look at what the literature shows. And so the American Society of Gastroenterology currently recommends early endoscopy within 24 hours to increase the diagnostic yield of colonoscopy. This paper that came out in Gastroenterology was a multi-center randomized controlled trial that enrolled a small number, 160 patients with moderate or severe hematochezia or melena, to early colonoscopy within 24 hours or elective colonoscopy within between 24 and 96 hours. And they were also followed through 30 days. The primary outcomes were stigmata of recent bleed, rebleeding, hospital length of stay, or death. Patients on average were 70 years old. They're about 66% male, and the elective group had more comorbidities and fewer events of severe bleeding. And diverticular bleed was the most common. In the early group, people received colonoscopy within 14 hours, on average of 14 hours from presentation, and in the elective group, about 41 hours. But notably, about half of patients still received their colonoscopy within 36 hours, so relatively early. And they found that there was no difference in the stigmata of recent bleeding, mortality, rebleeding, or hospital length of stay between the two groups. And a subgroup analysis based on the severity of bleeding showed similar results. From this, they concluded that early colonoscopy did not increase diagnostic yield or improve outcomes. And so if Mrs. C came in with hematochezia, a lower GI bleed, I would conclude here that in patients with a lower GI bleed, early endoscopy within 24 hours may not improve diagnostic yield, mortality, or further bleeding. But this likely only applies to diverticular bleeds, and our GI colleagues would still recommend that you involve them early, though they almost never need to be called overnight for these bleeds. All right, so GI take-home points. In non-varicose, hemodynamically stable, high-risk upper GI bleeds, non-urgent EGD may not improve outcomes. And in diverticular lower GI bleeds, early colonoscopy within 24 hours similarly may not improve outcomes. All right, well, we have 3 minutes left. What I can do is skip to my take-home points and skip the last updates in endocrinology, or we can kind of power through. Are there any thoughts or preferences?
I think there are mixed votes. So if you can do endocrine, I think there's more votes for a summary actually. So maybe
okay, why don't we go through that?
Summarize, yeah.
Cool. All right. So we'll just skip through. Oops. So the overall take-home points here: oral beta-lactams can be used in select patients with strep and GNR bacteremia. There is minimal risk of contrast-induced AKI if your GFR is greater than 30. The benefit of anticoagulation in patients with end-stage renal disease and AFib is unclear, but Apixaban is emerging as an alternative to Warfarin. And in patients with new AFib, consider an early cardiology referral or consult to discuss a rhythm control strategy. In non-variceal upper GI bleeds and diverticular lower GI bleeds, earlier endoscopy may not improve outcomes. And this is the last one that we didn't get to talk about, but have a low suspicion to evaluate for DKA in patients on SGLT2 inhibitors. And if people want to stay for me to go through that after the fact, I'm happy to do so. I just wanted to give a special thanks to the numerous subspecialists that I pestered to get their expert opinion across various different institutions. And then if you guys have any questions, I'm happy to try to answer them. Or if you want to email me, my email is yilin2@uw.edu. I'm always excited to discuss these papers more in depth. And if I need to reach out to get you an expert opinion, I'm happy to do so.
Well, thank you so much for a really comprehensive overview from the internist point of view. We are just at time, so I will just say thank you so much for going through really a wealth of knowledge for us in a really digestible way. So much appreciated, and I'll encourage folks if they have questions to reach out to you via email, but otherwise much appreciated. And thank you for folks who participated in the poll everywhere. Polling throughout. With that, I will close out our Department of Medicine Grand Rounds for 2020, and we will see you back here in 2021. So take care, and thank you again.